he was hit literally out of the blue with a horrible infection, very serious infection, while he was in the flight coming into Dubai.
What exactly happened?
Pictures were sent to Dr. Mohan to look at it because it was suspected that it might be necrotizing fasciitis, and you diagnosed it.
But sometimes the strep bacteria becomes very virulent and gets virulence factors. There are many reasons for it, many hypotheses, but it's overuse and abuse of antibiotics in the society that makes a certain bacteria resistant to antibiotics.
This is
Those
very
bacteria,
important.
Oftentimes, to confuse the issue, this happens after an exercise. We still don't know whether intense exercise has a causative or contributing factor to this.
So other than exercise, it doesn't appear like the pain cannot.
It can affect a completely healthy normal person, number one. More often it affects people who have some immune compromise, let's say diabetics or something like this.
So you need technique to do this, right?
I do what is called an avulsion technique, where the blood loss is minimal and I don't have to use drains.
Like very less blood loss.
Very, very less blood loss. So I've never had to transfuse blood to any of these people.
Welcome to this special collaborative episode between Med Talks by Dr. Anita and Expert Medical Insights by Dr. Mohan Rangaswamy. Today we are diving deep into a powerful and eye-opening conversation about plastic surgery beyond aesthetics, beyond fillers and beyond Botox. With esteemed pleasure with me is Dr. Mohan Rangaswamy, a highly experienced plastic surgeon known for his precision, advanced techniques and a comprehensive approach to reconstructive surgery as well as plastic surgery. His expertise goes far beyond cosmetic enhancements. He plays a critical role in life-saving and limb-saving procedures, working at the intersection of multiple medical specialties. We also have a very special guest today, Mark, who bravely fought against necrotizing fasciitis, a rare and aggressive infection that can change lives in an instant. His journey highlights the life-saving role of plastic surgery in emergency care, trauma, and complex wound management. In this episode, we'll explore how plastic surgeons contribute across medical fields like bariatrics, orthopedics, neurology, obstetrics and gynecology, pediatrics, and much more. Dr. Mohan will share insights into how his precision techniques have saved lives, restored function, and helped patients regain their confidence. So stay with us as we uncover the real impact of plastic surgery, where science, skill, and artistry come together to transform lives. Welcome on our show, Mr. Mark and Dr. Mohan.
Thank you once again. It's a pleasure to be with you every month.
Yes.
Sharing our knowledge, sharing information about plastic surgery to the world out there, and welcome to our viewers.
Yes, a warm welcome and a very warm welcome to Mark. I'm so thankful and obliged that you came to our show to discuss your entire journey with Dr. Mohan. So Dr. Mohan, for our audience who don't know about this the condition, what exactly is necrotizing fasciitis?
So I'd like to introduce Mr. Mark Brooks, first of all, who is the brave one here.
Thank you.
Okay. So he was hit literally out of the blue with a horrible infection, very serious infection, while he was in the flight coming into Dubai. This was in December 2023. Yes. And then he rapidly became very ill, very sick, and he got admitted in our hospital. And maybe we should hear a little bit from his side.
Sure.
Oh, absolutely. You fell sick while flying to Dubai. What exactly happened?
Well, I mean, if we look at the root cause, I think came from smacking my arm playing squash. So there was some small injury. It was compounded then when I had a sore throat and I went to the gym and tweaked it on a Smith machine. I did a pretty heavy session at the gym. And what I understand from this particular illness is I probably had streptococcus A in the throat. And because I had an injury, albeit a fairly light one.
A small internal bruise, yes.
So the cells from the throat were laid down onto the elbow, and it just felt quite painful. And so I flew into Dubai with a very painful arm, had a doctor have a look at it, and he said, well, it's not broken, it's not fractured, but if it gets worse, go to Al Zahra. So I rocked up at Al Zahra. 9 hours later, I basically started throwing up, and then I realized that that's really unlucky. I've got food poisoning and a really sore elbow.
So this was all acute. Together. It happened all of a sudden.
All within a day. All within a day.
Yeah, very quickly. So I showed up at Al Zahra, hypotensive, and then a big bruise popped up from nowhere. And so that was when compartment syndrome was suspected. And then I ended up on the table 3 hours later, and pictures were sent to Dr. Mohan to look at it because it was suspected that it might be necrotizing fasciitis, and you diagnosed it. And then essentially, I mean, it just compounded. The necrotizing fasciitis developed into muscle necrosis. I lost muscles as well. Blood sepsis led to multi-organ failure and the kidney shut down. So I had, in total, in a nutshell, 24 operations to rebuild, debride and rebuild the arm.
Wow.
And also 7 dialysis and 4 blood transfusions, and then the kidneys kicked back in, thank goodness. So yeah, I'm a very happy camper. There's still some more operations ahead to
restore some function.
Yeah, get the function, get the fingers fully functional. I've got 2 very beautifully working fingers, but the other 3 need a little work. I've lost some muscles in the mass as well. I must say there's a particularly creative time when the arm was really...
I was about to tell you to lift that.
So there we go. So basically what happened is this had no skin for 2 months. And then skin was taken off my leg to rebuild it. And essentially the way it was able to continue without skin, because it was essentially cling filmed up, if you like, and had a vacuum pump hanging off it. And so it was sealed in and protected, and then every few days I had to have it debrided and changed, cleaned up, debrided, changed, cleaned up, and that was the cycle. That's why there's so many operations. So thank goodness for the technology of having this vacuum pump, because 2 months there was no skin on the arm. But then we had a situation where the brachialis was gone. There was really nothing supporting this bone. And so what do we do?
He has done a complete research on his arm, and all the medical terminologies, everything.
Yeah. So what happened really was that this necrotizing fasciitis, aka flesh-eating bacterial infection, in the popular press it is mentioned like that. Flesh-eating bacteria. So there was spate of these infections reported widely in the world media, world press in the late 90s and early noughties, especially in cold countries like Canada, Northern Europe, and it's caused by particularly aggressive and virulent streptococcus. Now, strep throat is very common. We all know that this is a very common thing.
Throat
Streptococcus
infection
is all over the place. It's even normally present on the skin. But sometimes the strep bacteria becomes very virulent and gets virulence factors. And there are many reasons for it, many hypotheses, but it's overuse and abuse of antibiotics in the society that makes a certain bacteria resistant to antibiotics.
This is very important.
Yeah, those bacteria produce virulence factors, and they are very friendly. The community of bacteria, they're very friendly. They like each other. So one bacteria gives this package of information to Streptococcus. Here you have it for free. How to counteract antibiotics and how to be virulent. So when the Streptococcus, which is normally a strong bacterium, gets additional virulence factors, then it produces hyaluronidase, collagenase, and a whole host of enzymes. And then once it gets into the tissues, by some combination of factors, if it is favorable to the bacteria, it starts producing these enzymes. They run amok in the tissues. They go on killing the fascia especially. So it spreads under the skin. So over the skin, you don't see anything.
You cannot see anything from
but
the
top.
But
the patient feels a lot of pain. He comes to the ER. The ER doctor sees nothing on it. And sometimes they say maybe he's malingering or something like this, or maybe, he just has a little bit of a pain, sprain after, Oftentimes, to confuse the issue, this happens after an exercise. We still don't know whether intense exercise has a causative or a contributing factor to this.
So other than exercise, it doesn't appear like the pain cannot...
It can affect a completely healthy, normal person, number one. More often, it affects people who have some immune compromise, let's say diabetics or something like this. But Mark has none of those factors. So either way, this bacteria can attack people, any part of the body, generally the limbs, and then it spreads by the minute, by the hour. This is one infection that spreads by the minute.
Whoa.
The thing is, it is surreptitious. It's spreading under the skin, so the skin doesn't show anything. There is not even much swelling. Then once a sufficient area is involved, the overlying skin starts showing a bruise.
And how much time it takes?
Hours.
Okay.
Hours. Very often what happens, the patient comes into the ER, he gets checked up, nothing's wrong, some painkillers are prescribed, he goes home, 6 hours later he comes back extremely moribund. It can happen. I'm not wanting to create panic among people, but of course this is very rare. This is a rare condition. But the thing is, this condition can be dangerous to limb and life. All right. So how does this interface with plastic surgery as a specialty?
But then it's a very important takeaway that unnecessary use of antibiotics when it's not prescribed can also cause resistance.
For so many reasons, we should not be abusing antibiotics and so on. Okay, but that's a different topic. So coming back to the role of plastic surgery in such cases and many other cases that we shall discuss today.
Right.
So what happens is plastic surgeons, of course, are very familiar with this condition, more familiar than many other specialties. Let's put it that way. Why? Because wherever necrotizing fasciite happens and whoever is treating it is going to create a big raw area. There's going to be big areas of skin loss, fascia loss, sometimes muscle loss. There are going to be big wounds. So who is going to sort out these big wounds? So ultimately it will come to a plastic surgeon. So because we get referred these cases at a later stage, many of us want to get involved earlier. So what happens is, yes, any surgeon, any experienced surgeon can do debridement, can recognize dead from living and take away the dead tissues. But if a plastic surgeon gets involved in the beginning, he or she may be able to contribute to selectivity and also to protect important structures and provide emergency coverage by using many of our specialized techniques to vital structures which may get exposed. In another way, an average surgeon may be afraid to take away so much of tissue. He will say, like, how can I take out? How can I? What's going to happen? Will the limb be saved? And how can I? So he may be timid. So it's well known, survival of a patient of necrotizing fasciitis is directly related to the aggressiveness of the initial surgeon. What I mean by that is the initial surgeon must be confident enough to do a widespread, as necessary, debridement and follow it through 24 hours later, 48 hours later with a second look and a third look.
That we don't leave anything behind.
No, not just that. To keep one step ahead of this bacteria.
Okay.
So aggressive debridement improves the survival. The earlier the debridement is done, the more aggressive that it is done, it impacts on survival. So this is why if plastic surgeons get called in early, so we can, together with the surgeon perhaps, we can form a team and we can, do an effective debridement. This is the first part. This is important to save lives.
Right.
Of course, such patients require intensive care, require multiple specialists to look after them, antibiotic support and all that, like dialysis in him, sometimes ventilator and all that. And an important point a little later comes hyperbaric oxygen, which we used, like high pressure oxygen chamber, which is available in Zahra Hospital. So all these helps.
It really helps, huh?
So what happens is once this phase is over and the disease is under control, of course we have lost a lot of tissue, a lot of muscles, then it comes the reconstructive part. But we cannot jump into reconstruction straight away because the tissues are still messy. We need to build up the tissues so that they become clean, like millimeter clean. So that's why it requires repeated debridements. And here we use a technique called negative pressure wound therapy, which Mark mentioned. So we do that and we use a bunch of other techniques to ensure. But what is important in his case...
something must have been challenging in his case,
In his case was really challenging because even the muscles died. So the muscles close to the humerus bone on both sides, they died. So the bone got kind of isolated without any muscle cover on it. So there was a period when I was really anxious that the bone might die also. Secondly, he had important structures like the blood vessels and the nerves exposed, and exposed nerves will just dehydrate and die. Even if we put the negative pressure and we do everything, we need to cover the nerves and vessels with something very quick. Now, since the limb is still messy, within quotes, like somewhat infected, we cannot do flaps. So I had to innovate some new methods, which is coming from regenerative medicine. So regenerative meaning using the power of your own body cells. So I took some fat from his tummy by mini liposuction and used the fat with platelet-rich plasma from himself. So he healed himself, so to speak.
Wow. This was which year, you said?
This is last year.
Last year only.
The first half of 24.
Another wonder of fat grafting.
So not just fat grafting in the usual way. So here I condensed the fat, I used the platelet-rich plasma, and then I used some matrix materials, and I made a concrete cement mixture out of it, so to speak.
Wow.
And then we packed it into the empty spaces to surround the bone with this grafted fat. And the beauty of it was, because it contains stem cells, the whole thing integrated very well and became tissue. And I could put skin graft on top of it. And also the nerve got protected. Nice. So we squirted fat directly on the nerve.
Not quite squirted. You use a very special tool.
Set of tools. You want to know what those tools are?
Yeah, of course. I'm so excited to hear about
this comes from kitchen. And it's called a teaspoon and a butter knife.
What was that?
Literally, in order to put the fat in, the best instrument is a spoon. So you can take a stainless steel spoon, sterilize it, autoclave it. So it's a sterile instrument. It's a stainless steel
You're
instrument.
seriously kidding me?
I'm serious.
Okay.
I'm serious.
All right. Wow.
Okay.
I remember the day well. I was like, I've got a special tool. And he just pulled out a teaspoon and said, we're going to use this.
Oh my goodness.
All right. Because to pack the fat deep into all the crevices, a spoon works better than many surgical instruments. But anyway, that's just a aside.
Right.
So-
Was it painful?
No, he's
It
sleeping.
wasn't.
He's sleeping.
No, I mean the journey till reaching Dr. Mohan, it was painful. It's too painful, right?
He had pain in
Day
the
one.
beginning. Yeah.
Uh-huh.
After that, once the debridements, etc. are done, it's not that painful.
Okay.
Surprisingly painful.
Surprisingly painful,
except the skin graft. And I remember that day.
That's
you
in the
said,
thigh, in the thigh.
Yeah, you said basically the arm is going to be okay. The skin, where it's coming from,
The donor side.
Oh,
the
the
donor
donor
side
that's
might
going
have
to be
it. Right.
worse than the arm. And that was a bit, that was quite painful.
But then
the
there is
rest has
another
been great.
thing that, okay, so the fat was used and we could do a skin graft, etc. But then it still required another major surgery, which we did later on, which is a flap from the back. So,
Okay.
so muscle and
Muscle
skin
flap.
flap. So this skin that you see here was not there.
Oh, not at
All
all.
of it's gone.
This skin is from his back.
The arm was about
Much of this
two-thirds.
muscle was gone.
Yeah.
This muscle is also coming from his back.
Very little volume. So the latimus dorsi was pulled over to rebuild the tricep. The tricep had been also
Partially
lost some
gone,
of the
partially
tricep.
lost, yeah.
And the tendon was a real mess. That was just continued. This is the last bit to heal up, and it was just so difficult to get healed up. But you basically pulled the latimus dorsi out, including the insertion from the hip,
Yes.
and brought it around, and then
Yes,
meshed
that's right.
the tendon into the existing tendon with the tricep.
He can be another plastic
so
surgeon
what's
in a few
interesting
months.
is I can fire up the tricep.
Oh.
And I can fire up then, I can't do it on, I can do the tricep on its own, and then I can do the tricep and the latimus dorsi, and I can fire both up.
So those are working, but because during all this illness, it also affected his elbow joint, and he got a pathological fracture there. So it's a bit frozen. We're waiting for time for the elbow to improve. It is improving somewhat, but we may have to do other things in future.
Yeah.
So the point here is that such devastating injuries or devastating infections, which affect multiple tissues and result in loss, deformities, plastic surgeons have a big role to play. Very often, unfortunately, we are called in much later, and we
Right.
wish we are involved from the earlier stages.
Right.
This is one message I want to give to the doctors out there, that in many, many conditions, plastic surgeons, especially those who are a little bit oriented towards reconstructive surgery, such as myself, because it allows us to gently influence the treatment from the beginning in favor of the patient and in favor of the reconstructive methods we may have to use later on.
Can you give an example?
For example, if somebody needs to do a debridement and wants to make a cut in this direction or that direction, if I am there, I will guide the cut to be made in a particular direction so that it does not compromise my future flaps and future reconstructive
Right.
options. Otherwise, a person may make some random cut, and when I get to see the patient, I say, why did he make this incision here?
Right.
Shouldn't be here, because that is compromising my reconstructive option. So one option is gone.
Right.
So this is another reason why
Early intervention.
collaborative treatment from the beginning would be very good for the forward planning for the particular case.
Right.
But besides that, early intervention, early involvement of the plastic surgeon also allows us to start thinking of the best way to help this particular patient, and we can talk to the patient from the beginning, give him hope at a time when his confidence level and hope level is at rock bottom. So we can tell him, okay, no, don't worry, I'm there to rebuild this tissue once you get over this crisis. So that is also a confidence booster and a morale booster to the patient.
Absolutely.
So it in modern multidisciplinary care in good hospitals where reconstructive plastic surgeons are active and available, they are often consulted. So
It's very important.
That is actually one of the aims of today's podcast, is to showcase how plastic surgeons contribute to multiple medical specialties in specific problem areas in each specialty.
True.
Yeah.
True. I think this is something which often gets missed out. Plastic surgeons' involvement in certain surgeries and cases where definitely early intervention plays a very big role.
General public may not know this, and for some various reasons, even the general medical doctors do not understand or do not know or are not aware that plastic surgeons have so much to contribute in each of their individual areas of specialization.
Agree.
Or, for example, a family medicine doctor needs to know, because the patient will often
Come to the family medicine
confide in
doctor.
the general practitioner, GP, or the family medicine to ask for help or referrals.
Right.
And the GP doesn't know that this problem can be
Solved by a plastic surgeon.
So we plan to do it alphabetically.
Oh yes, we will go there.
Yes.
We are just finishing with Mr. Mark. I think he jumped directly on the topic.
So I've got a question for you. I nearly ended up in England with this problem. I wonder what the outcome would have looked like if I'd been in the public health system versus a private health system.
Well, this is a difficult question to answer. It's not to do with the private or the public. It depends on what expertise is available locally in the hospital that you go to.
Yeah.
If you go to a certain hospital where there are plastic surgeons available, or they can collaborate in the region with another plastic surgeon, I'm sure it can be dealt with, the initial stages that you went through. Regarding the later stages where the regenerative aspects and other things, that is left to individual surgeons' skill, expertise, imagination, experience, and so on. Because I often like to say that one of the requirements for a plastic surgeon is to have a 3D imagination. Sometimes unreasonable imagination to start with. You need to think very broadly, and then narrow it down and temper it with realism and temper it with what has been published, what is on the evidence-based medicine. But in the beginning, you have to imagine big.
Absolutely agree.
And you have to break down the deformity or the problem into its elements,
Right.
and analyze each element and see how I can address this,
Right.
and have maybe 3 or 4 plans, plan A, B, C, D, and then do a mental dialogue with yourself or with another colleague if available,
Right.
and choose the best plan that fits this particular. So this is how plastic surgery differs from other specialties,
specialties.
because we don't have fixed formulas for things.
True.
And we are often called upon to deal with situations where we have to just imagine and
you
work
make it
backwards
real.
and work
Dr. Mohan
backwards
makes those imaginations real.
and work,
I was
and
quite
work backwards.
blown away having the conversation around, like, what do we do with this arm? How do I get it to actually function now that it's 2/3 the size? How do we feed the bone? And then you came up with, let's swing the latimus dorsi over along with the flap of skin. I would never have imagined that was even
That's
possible.
Dr. Mohan.
That is standard.
Yeah.
That
It's great.
That's
It's
a
worked out
standard
very well.
technique.
It's-
That's a standard technique.
It came out really well. It's
but
beautiful.
application in this situation at the early stages, that
Is
was
something very
slightly
crucial.
different. Yeah.
I consider myself exceedingly lucky in 2 particular areas. Number one, that I wasn't in England, that I was actually on the plane and landed at Al Zahra Hospital, a private hospital, rather than a more resource-driven decision in a public health system. I think it would have had a very different outcome. I probably wouldn't have the arm. I probably would have still lived. But it was a 50-50 thing, from my understanding, with this compounding situation I had. It was a 50-50 mortality rate. So I was lucky to land on Al Zahra, but I was even luckier to land on a reconstructive surgeon, and one with considerable experience. And I think that's... I got nothing
You're
but
blessed in
thankful
that sense. Absolutely
to have
agree.
those 2 things happen.
So I'm glad it went very well. And in fact, there was another gentleman, Indian gentleman, who had got the same exact disease. They have become friends now.
Yeah.
And who
Also
came to us a
Jim.
few months.
Also Jim.
Yeah, he had
Follow
the
Jim.
gym
Gym
on
goers
his
have
leg.
to be very careful. That it's not always just the injury. You have to,
Unusual, and that it's
Right.
kind of unusual because
So
we're both from the
he
gym.
also had pretty severe in the lower limb. He also had muscle loss. So the muscle loss in him was very unusual. Normally, necrotizing fasciitis does not involve muscles except in the severe category, where it can involve muscles as well.
Okay.
Here, the unique part was, and I'm glad, I don't know what thinking came on that day. Let me just dig a little bit deeper and make sure that the deeper muscle is also okay. Maybe because I had a muscle necrosis in the previous patient
Okay.
in the leg. So the superficial muscles looked good. Some of the muscles were dead, which I had removed, and everything looked fine. The biceps looked fine. So I said, let me lift the biceps, go inside and see what's the brachialis. That's the next muscle. And that was totally dead.
Oh.
End to end dead. And that
And
was
top muscle was completely
completely
fine.
normal. So this bacteria has skipped one muscle layer and gone to the deeper.
down creepy one. Huh?
This is unusual.
Okay.
This is unusual. And I'm glad I found it on that particular day. Otherwise, that would have continued to spread
Continue to-
infection upwards
yes.
into his main body.
I think I know
that
why.
that was a very important discovery that we made.
Wonderful.
And then
I
we
did hit that muscle group. I did overdo it at the gym
Could be.
with the curls.
Could be there was a internal bruising in the muscle which provided a small hematoma, small collection of blood,
Right.
where the bacteria could come from the throat via the blood, sit there, and find, hey, the conditions here look good.
It looks amazing.
Looks
Let's
good.
grow here.
let's sit here and grow.
That's so true.
Yeah, so something like that.
How was your overall journey with Dr. Mohan, Mark?
Look, I mean, it's just, I just consider myself exceedingly lucky to land on someone that could carry the full journey with me. And I look at the various decisions around this, and it's been relatively, I would say it's almost been a cakewalk in terms of if you could, like, people look at the arm and think that looks really painful, that looks terrible. I've really not had that much pain from it, which is miraculous.
Wow.
And I consider myself very lucky because I've been in very good hands. It's been a very good team all throughout. I've been in relatively low amounts of pain except for the skin graft. But that comes with the territory.
Not really always. It's just that he had some of the dressing slipped and all that. These are things which can happen. So we tell them that donor site might be more painful than the other sites.
Right.
Okay.
Yeah.
But still came out very well.
Yeah, I'm very happy with it.
In spite of all these complications happening where you were undergoing dialysis and all that stuff, didn't you had fear that it might not really go well?
The scary part was the kidney failure. I was not looking forward to having a...
But he's a very positive person. Yeah. And all through my treatment and my association with him, I've been really struck by how positive-minded he was. And he had a good amount of trust in me.
Right.
We don't know each other from before, but he somehow trusted me. And that helps, because when you want to take a decision, sometimes the patients, out of fear or out of subconscious mistrust, they may not go with your plan.
Yes.
And in this condition, certain things have to be done at certain time. Like you delay things get worse.
Right.
But he was always up for it. Because people get scared. Okay, how many surgeries? I've already done 10. How many more surgeries, doctor? Those sort of things.
True.
We didn't have those combative movements with him. We don't had those difficult
a complete
discussions.
Blind trust on the right person, probably, I would
so
say.
He
swimming downstream.
He was.
That's the way I figure.
He was trusting of me. And so we could take decisions, and then his insurance was very supportive. That's a very, very important thing. Oftentimes, in today's managed care, insurance delays approvals.
True.
And then you lose valuable time. Okay. And so every time we needed to do a procedure like tomorrow, like after 2 days, we could do it.
Right.
So part of the success is because we could do things at appointed times.
When it was really needed.
And when it was needed, no resistance from him and support from the insurance. And
the best person to do it?
The hospital anesthesia department also was... See, after some few surgeries, we got it all worked out.
Right.
So everybody knew, okay, Mark is coming tomorrow. Okay, Mark is coming after 2 days. So it was all going very well.
Amazing.
Yeah. Each surgery took time, of course. We had to spend a lot of time because we had to do detailed work. But that's the thing. You have to do a lot of detailed debridement every time.
Right.
So time, effort, resources spent on these kind of conditions is huge. But that's what it requires.
Any takeaway from Mark's case you would like to give to the audience, Dr. Mohan?
Well, the thing is, it's not as if necrotizing fasciitis happens every day, but it does happen a few times in a year in any big hospital, let's say. So it's for the ER doctors who will be the first set of doctors to see emergency room doctors. And also the surgeons that they may call upon must have a index of suspicion to say that could this be necrotizing fasciitis?
Right.
If the patient, so there are a few things. I mean, I'm not planning to get into the medical aspects of it, but there are, and I've written up articles on this, and there is information available on the internet. So basically, a high index of suspicion. And if you suspect, you can do an MRI scan. And what I recommend is to make a small incision, which I have done a couple of times, to look at the fascia directly. And that gives you the diagnosis in 5 minutes.
Right away. Right.
Direct approach.
Right.
And I prefer the direct approach. And since his case, a couple of times I have been called in to see, is this necrotizing? Because the hospital got sensitized.
Right.
And some of those patients, I do the direct approach and I say, okay, this is not, or this is. And then we could proceed accordingly.
But this is for doctors. Otherwise, for normal people, layman people, how do they can question also? I mean, even if people are aware, they can question the doctor. This might be the scenario, right? So how they come to know that they can ask the doctor?
It's very difficult. I mean, there are hundreds and thousands of medical conditions which sometimes masquerade as something else, difficult to diagnose.
Right.
But this condition, basically, public cannot be educated on this condition. Prevention, yes. like he said, don't overdo your gym workouts. And if after any such minor trauma or overexertion in the gym, you get serious pain, don't think that, okay, I might have pulled something. Like really serious pain, which is getting worse and worse by the minutes and by the hours. That is serious.
I went
And
round and round my
and if you're not feeling well, if you're feeling dizzy, appetite goes away, you just don't feel well. Unfortunately, there's not much of a high fever in this, but the pulse rate will be high.
Oh.
The person will feel unwell, and there will be an extraordinary amount of pain in that area with nothing to see.
Right.
So that combination of not being well and extreme pain, getting worse by the hour, that maybe people can remember that there should be something
it's
serious.
Very important for
it's
gym goers.
important.
I mean, I can figure out the importance because I'm a gym freak as well.
It's not necessarily
sometimes
gym.
people may think just it's
Minor
just a
trauma,
strain or something,
minor trauma,
and keep avoiding.
But then one important thing is people who are immunocompromised, especially diabetics, they are more at risk. They should be careful of this one.
I think there's some compounding factors with the gym workout. It was a very unusual gym workout that I did. It was cold. It was in England. It was a very cold gym for some reason, to the point that I complained. And I only had one layer on, and I didn't bother putting another layer on because I didn't have it. And I did 11.3 tons. I know that because it's on Fitbod, an app that I use. And I took an hour and a quarter. And whenever you go beyond an hour, you risk cortisol spikes. So there's the stress involvement as well. So I think 45 minutes is plenty in a gym.
Oh, I'm a 2 hours person. Ask me.
Well, obviously, this is a rare event,
right?
So we need to keep things in perspective. But
True.
yes, but since this is a serious
condition which can really,
it's supposed to be more common in cold countries. It was believed that it doesn't exist much in the Middle East. But when I was in Oman, I saw 10 cases. So I wrote the first article from the Middle East on necrotizing fasciitis to highlight that this condition does exist and what are the ways in which it can masquerade and how to diagnose it and how to suspect it and how to treat it. That was published way back in 1998, I think, if I remember
amazing.
right. Yeah.
That's amazing. Well, so that was really an amazing journey with Dr. Mohan, I would say, that you literally landed up saving your limb. It's
life.
And life as well,
and
yes.
In combination.
So many number of dialysis. It was a complicated case, I would say. But great, thanks to Dr. Mohan. Yeah, I mean,
we still have a bunch of surgeries lined up for him. I need to get back function to these 2 fingers and to the thumb, which we are hopeful of. And finally, if all goes well, we'll be able to bring back some good skin here, normal looking skin from his abdomen. I'm planning to do that. This part is already sorted.
Okay.
And this part, we need to get this tendon back into the bone. I think internally it was so weak that might have ruptured. We need to reattach it to the bone to get the elbow function. And we are waiting for his elbow joint to loosen up. It's right now a little bit frozen, but it's getting better slowly.
Right.
And so there's a lot of work still to be done, maybe for the next year and a half, but we'll take it one step at a time. There's no urgency now.
Right.
It has to be done at a time that is the best for him. Because in reconstructive plastic surgery, we say, and it's written in books and is said by the gurus, that if anything can be honorably postponed, it should be postponed.
Wow.
What that means is that don't rush into surgery after surgery, and let the tissues resolve. Let whatever hardness and fibrosis resolve.
Give it time.
Then you come for the next set of reconstructive work.
Wonderful.
So yeah, we
Thank
look
you so
forward
much
to seeing
for
you
being
again.
with us, Mark.
Thank you.
It was an honor to have you. Thank you.
Thank you.
So that was really an amazing case to discuss,
It
Dr.
was.
Mohan. It was an amazing job saving a limb. It's really crucial for our doctors to understand that early intervention really plays a very important role. We have to involve plastic surgeons as early as possible in certain cases. So we'll be discussing each specialty wise what role plastic surgery plays in saving or the importance of
contributing to or solving special problems in different specialties.
Right. So coming to bariatric, I mean starting with bariatric.
You're starting with B. Alphabetically. Okay.
Yes.
So B for bariatric. So bariatric surgery has become very popular now. And for those that don't know what this term means, these are surgeries which are designed for massive weight loss.
Right.
Okay. So people who are very heavy, 120, 150, 200 kilos, there are these surgeries that are done which are very effective in weight loss.
Right.
But the problem is the person will have lots of loose skin in the arms, in the tummy, in the back, the buttocks will fall down, maybe the breast in a woman will sag.
Even post Mounjaro and Ozempic also this
nowadays,
happens, right?
Nowadays, instead of
common.
surgery, some people are using these weight loss medications,
Right.
injections like Mounjaro and Ozempic and all
Right.
that.
So same situation happens in
Same
this.
situation happens. So when they lose a lot of weight, there's a lot of sagging of the tissues. Tissues move south. Now a lot of people wrongly believe that they can hit the gym and the skin will shrink. Exercise doesn't have any effect on this loose skin.
Loose skin.
So, and plastic surgery has excellent techniques now to rebuild the body and lift up all the sagging tissues, get rid of all this massive excess of skin and tissues that are there. So it's no longer just a cosmetic surgery for these people, it's almost reconstructing the whole body. So we do multiple surgeries for the arms, for the chest, for the breast, tummy, buttocks, and inner thighs in order to restore these people. Now the important thing in this, where plastic surgeons of course are involved in these, it's a good idea for the patient who's undergoing bariatric surgery to come and see a plastic surgeon early in the journey. Earlier in the journey, so that we can choose the right time to intervene, and we can also guide them on how their weight loss journey goes and what exercises to do, what garments sometimes to wear in order to minimize this sagging of the skin. So this is one area post-bariatric that plastic surgeons contribute. Now these surgeries used to be risky, but now with experiences and for plastic surgeons who are used to doing this on a regular basis, we can do this with very little complication. I don't use drains.
You're talking about some technique,
I don't
a
use
unique
drains.
technique to
Yes,
do this, right?
I do what is called an avulsion technique, where the blood loss is minimal and I don't have to use drains.
Like very less blood loss.
Very, very less blood loss. So I've never had to transfuse blood to any of these people. So that's B. Now B is also for burn injury.
Burns,
Of
yes.
course, everybody associates burn with plastic surgery. I mean, plastic surgeons are well known to be the appropriate specialty to deal with burns. But minor burns are often dealt with by ER people, by the dermatologists, sometimes by pediatricians, sometimes by surgeons, let's say.
Like kids' burns and also
Yes, exactly.
very commonly.
So it's not possible for every burn patient to see a plastic surgeon straight away.
Right.
But any significant burns.
Well, they don't know. Let me tell you, they don't
Besides
know.
that, minor burns probably can be managed by any doctor if it is superficial. So important point here is facial burns. Burns are specialized areas like genital areas and hands.
Okay.
So genital, hands, face. Or areas where the burn is more than 10-15% of the body surface area, or the burn is deep. Or specialized burns like electrical burns, like lightning, like industrial burns due to some chemicals and stuff. These need to be seen by plastic surgeon as soon as possible, preferably in the first 3 to 5 days. Okay, so where we can do planning for the treatment of these and for the best option, best treatment.
Right.
After B comes D. Well, C is cardiology. We don't have much to do with cardiologists. But dermatologists, yes, dermatologists
also.
do refer a lot of cases to us. And this is an area where skin cancer, for example, even dermatoaesthetics, it's best if the patient looking for aesthetic improvement is managed by a cosmetic dermatologist and a plastic surgeon. Each of us bring our skill sets to the table, and the patient can get the best benefit out of consulting both specialties.
So there is always a war between aesthetic doctors and plastic surgeons for doing certain procedures when it comes to aesthetics. So I want to know how we can define it. How it can be defined.
True. For example, nowadays a lot of these Botox and fillers are being done by dermatologists, and plastic surgeons also do them, so that's fine, that's common area. But certain things like invasive thread lifts, even in the minimal treatment, thread lifts and certain mini-invasive laser treatments which are internal, these are better to be done by plastic surgeons. Fat grafting, again, some dermatologists get skilled in it. They acquire these skills and they're able to do fat grafting, but still fat grafting is mostly with plastic surgeons. I'm not talking about major surgeries, I'm talking about minor minimally invasive work. Of course, surgeries like blepharoplasty for upper lid, facelift, nose surgeries, chin augmentation, all these fall under plastic surgery. What happens is sometimes a particular specialist, if it is a plastic surgeon or if it is a dermatologist, they are focusing on their area and using their techniques what they can do. But maybe the other specialty also has something to contribute. So where the business situation allows, if both these specialists talk to each other and evolve a common plan for the patient, then that's the best. That is the best, and that we are able to accomplish in the 2 hospitals that I work. We are able to have a healthy collaboration between the 2. Dermatologists also, they refer some medical conditions, like for example, excessive sweating in the underarms. There's a condition called hidradenitis in which I have a special interest and I have contributions.
Right.
So skin cancer is a very important area where the diagnostic part lies with the dermatologist, the treatment part lies with the plastic surgeon to give the best possible cosmetic outcome as well as get rid of the cancer.
Right.
All right.
Right.
So derma and plastic, there's a lot of interaction.
Wonderful. I have a question, Dr.
Yes.
Mohan. So in case if some people, like when they want to go a jaw enhancement or a nose enhancement, many Botox and fillers are available nowadays where patients, they approach doctors to get this done. What difference it makes to see an aesthetic doctor for this procedure and seeing a plastic surgeon? How can we differentiate between the two?
So generally when, I don't mean disrespect to anybody.
Absolutely.
But there's a saying that when you have a hammer in your hand, everything looks like a nail. So somebody who has 1, 2 and 3 kind of procedures that they can do, they try to do the maximum with that, like with filler, with threads and with all this.
Right.
That may not be the most appropriate in that situation.
Right.
What we are seeing now when patients come to us for facelift or for surgical, this patient has already undergone hundreds of fillers and threads and what have you. So the surgery becomes more difficult. It's difficult to give the results, while at the same time the patient is expecting the results because they've tried everything. Now it's not giving results to them. Now they want to come to a plastic surgeon and get things done, and the surgery becomes immensely more difficult.
Right.
So this is why a good collaboration and forward planning is important.
Right.
Maybe from patient's point of view, if they do a consultation with an aesthetic doctor and the doctor outlines that, okay, I am going to do this.
Right.
Maybe if the problem is significant, they can also see a plastic surgeon and hear the plastic surgeon's side of what he or she can offer, and then come to a personal decision as what they want to do. See, everybody doesn't want to jump into surgery.
Right.
Botox definitely is, both of us do, both specialties do. Botox, there's nothing to argue about. Fillers, yes, to some extent, 1, 2, 3 syringes is fine. It's fine. But if a face requires a major amount of work and if you have to use 10 syringes, it's better off with the surgery.
But why? What difference will it make?
But too many syringes of fillers are not going to really give you the result, and it's going to have gel everywhere and it's going to look grotesque, and then future surgery becomes very challenging. Very difficult.
Right, right. Yeah. So that covers our D for derma. It was a very important one. Great. So coming to the next. E is for emergency medicine. Oh, very important.
Yes. So when we get calls from ERs, where the plastic surgeon's contribution is really important is in hand injuries, to see if there is nerve or tendon injuries, if there is a diagnostic doubt that the doctor has in the ER, and facial and other injuries which are more complex.
Right.
I don't want to be called for every small 1 centimeter cut, which the ER can manage. But anything which involves injuries near the eye, the nose, the mouth, or very big wounds, complex wounds, flap wounds. And then these wounds, if the plastic surgeon is not available on that first day, they can be washed, they can be cleaned, sterile dressing can be applied, and the consultation can be organized the next day. This much time loss is not going to make any difference.
Right.
As long as initial wound cleaning is done properly.
Right. Okay. But it's very important for our audience to know as well that whenever they come across certain when they come to emergency, they should know that they have to look for a plastic surgeon.
Not necessarily.
Not always they are guided for this.
Not necessarily. No, that's a wrong message to send.
Really?
Because if every 1 centimeter wound in a kid, they start asking for a plastic surgeon, it's just not practical.
No, other than that, the cases which you mentioned just before.
So it's for the ER doctor to decide. And of course, a particular patient may want, as a personal decide, that I want to be treated by a plastic surgeon.
Right.
Yes, they have their right. In that case, the ER doctor can wash and clean the wound, apply steri-strips or something, put a sterile dressing, start on some antibiotics, and next day, the plastic surgeon can see and take over and do the suturing. And if it is possible on the same day, why not? So it all depends on the logistics of that particular hospital and the availability of the plastic surgeon.
Right.
But ER does refer cases to us, and so with ER we interact quite a bit. We come next to
F. Connecting it to F, yes. F and O also is there in my mind because orthopedics, it's more of a trauma.
So F is for family medicine.
F is for family medicine. Okay, well, let's get on that.
So we need to sensitize family medicine doctors, GP doctors, on what are the different possibilities that plastic surgeons can offer. Very often they are not aware. For example, you may not be aware that carpal tunnel syndrome can be treated very well by plastic surgeons, right? So patients consult with their GP doctor or family medicine doctor if they have a particular problem. And if the GP doctors know the full range of what a plastic surgeon can offer, both reconstructive and cosmetic wise, then a suitable referral can be. So we do get referrals from family medicine when they are not sure about it and they think maybe plastic surgeon can help in this. And in the Alzara Hospital, for example, we share a same floor, so referrals are easy.
What kind of cases usually? I mean, most commonly
Could
with
be
family
anything.
medicines?
Could be anything. Could be anything that the patient is asking the family medicine, and where it involves repair or reconstruction of a structure. Let's say, for an extreme example, let's say somebody had a childbirth and had episiotomy, and the episiotomy didn't heal well. And then, they finished with the baby birth and baby is growing well. And then sometimes the woman is asking her family medicine doctor, I have this problem. I have pain in that area. What can I do?
We jump to O.
So if the family medicine doctor knows,
Yeah, even
that
family medicine, yes.
doctor knows that
Right.
plastic surgeons can contribute in this area.
Right.
That's what I mean. So from F to O.
Yes, we came to the most important one.
Okay,
Yes.
but in between there is H. H is hand.
Oh, hand surgery, yes.
Yes. So plastic surgeons, those that have a training in hand, like myself, we are very interested and also competent to do repair and reconstruction in hand. It can be hand injury, it can be hand deformity, by birth, by trauma, by disease, and all that. So hand is an area which somehow falls in between, orthopedic and general surgery and sometimes plastic. But sometimes in many places, nobody takes ownership of the hand.
Right.
And hand is such an important organ.
True.
So today in modern medicine, we have plastic surgeons trained in hand. This is one group. Orthopedic surgeons trained in hand. This is the other group.
Okay.
Both these type of surgeons who have special experience, expertise or training in hand can deal with hand. And I
Alright.
think only these people should deal with hand, because hand is a very specialized organ and some small simple things can lead to stiffness. So it's very important that hand be seen by plastic surgeons that have an experience in hand, or ortho with a hand subspecialty.
Right. It's very important.
So from H
From
we
H
move to G,
G.
G, H, I.
We have G and G gastro.
Gastro, we don't have anything
Nothing
much to
much.
do.
Yeah.
Okay, I is infectious diseases.
And internal medicine comes with
Internal
family
medicine,
medicine is the
again,
same.
it's the
We
same.
cover, right?
K, L,
M.
M, N.
O.
Okay, N.
N for?
Neurology.
Neurology, yes.
Yeah. So people may not know that for peripheral nerve problems, plastic surgeons have a solution. For example, carpal tunnel syndrome, cubital tunnel syndrome, ulnar nerve entrapments, brachial plexus injuries.
Well, I didn't know as well.
So
And many times, trust me, we don't
So,
refer.
peripheral nerve
it's just
surgery.
landing with orthopedic doctors and they
That's
keep
right.
visiting them again and again.
That's right. Barring a few exceptions, most orthopedic doctors are not so interested in nerve-related problems. There are some who are. But again, reconstructive plastic surgeons, nerve forms an important part of our training and our repertoire. So we deal with all the nerve problems in the upper limb, especially, sometimes in the face. Facial paralysis, for example, is an area where plastic surgeons contribute in a very big way.
Facial paralysis.
Bell's palsy and these kind of conditions. So nerve-related
weakness of the
Yes.
face, such
And
conditions.
then movement disorders like blepharospasm, like torticollis. These are conditions where the muscles are undergoing
Continuous
spasm.
spasm.
So we use Botox. For example, children with cerebral palsy, the muscles are stiff. We can select out the stiff muscles and block them with Botox. It improves the hand function.
Wow.
So there are areas where neurologist and plastic surgeon can collaborate very well for the benefit of the patient. Yeah?
Absolutely.
So this is
That covers our
N. O.
Obstetrics and gynecology.
Obstetrics and gynecology and orthopedics.
Together.
So OB-GYN, tremendous scope.
Yeah,
Scope.
true.
Of course, they can be the source or referral doctors for aesthetic issues related to breast, related to abdomen, related to things consequent upon pregnancy. All right. Like I mentioned also, the genital area, I do complete cosmetic gynecology work. So that is another area where we can contribute.
Right.
Fat grafting, for example. So microsurgery sometimes is useful in tubal recanalization. You can think of tubectomy and tubal recanalization. We don't do tubectomy, but tubal recanalization can be contributed by plastic surgeon because the results are better with microsurgery.
Wow.
Similarly, vasectomy reversals, plastic surgeons can do because we use microsurgical techniques and the results are superior when you use microsurgery.
Right.
So microsurgery has a variety of applications in different specialties. And OB-GYN is an important area where we can contribute a lot.
Right.
For example, due to pregnancies, they may have a huge hernia, huge separation of the muscles, and the future pregnancies may be difficult. And such cases do get referred to me for doing an abdominoplasty or doing a repair.
Right. But
So-
then also for the episiotomy repair, I mean, normally the
No,
gynecologist
of course the
they do it.
gynecologist will do, but the
What
failed
difference?
repairs.
Failed repairs can be
Failed
referred.
repairs due to infection or whatever, or if the repair, the inner muscles got loosened,
Right.
then that can be sorted out. And I can also combine my regenerative techniques like fat grafting, PRP grafting, and all these things, which enhance the result.
Okay. Very commonly the
and
weaknesses we come
and we
across.
have the laser, so we can do laser rejuvenation for the vaginal mucosa. So combination of various skills
Right.
and equipments and techniques can be put together into one area.
Right.
So that's where the difference comes in.
Right.
So it's of course the gynecologist's own legitimate area. She can do it. But when they want to refer such patients to us, we can do it also, and we can use our techniques additionally to give the best possible outcome.
That's wonderful. So the same time or post, I mean, how much time after the delivery they can
No,
they can refer?
this depends on case to case. Maybe 2-3 months later, if there is a feeling that the woman has that she's loose or something is there or not right or painful or whatever.
So the pain should go, right? There shouldn't be pain after the delivery.
There should not be. After the healing period is over, there shouldn't
Right,
be.
right.
Yeah, if the area is still painful, then we need to look into it.
Right.
Sometimes just simple fat grafting will sort out the pain because maybe some nerves are entrapped.
Okay.
So we check it out, we check out if the muscles are okay. If they
Right.
don't need repair, there is no need to open and do a muscle repair.
Wonderful.
Then we can just manage with fat grafting.
Wonderful.
We did OB-GYN. We still have to talk about orthopedic.
Orthopedic, yes, it's a big area to cover when it comes to plastic
That's right.
surgery. The
That's right.
collaboration is really important. But we are short of time. I believe we need one more show to talk about how plastic
will.
surgery can work hand in hand with other specialities.
Yes.
And, we can have better outcomes and better results helping patients and the community as well. So, see you at the next podcast show, Dr.
Absolutely,
Mohan.
absolutely. There's a
Our
lot to talk
conversation
about.
is never going to end.
Not enough
Hopefully.
time to
Yes,
cover all the topics.
Absolutely.
And that is just a testament to the range and scope of this comprehensive field called plastic and reconstructive surgery. Would you believe that our textbook has 6 to 8 volumes?
Whoa.
Yes.
Wow.
So that tells you something about the
extensiveness.
the range and the extensive range,
Wonderful.
yes.
We have a lot
We'll
to
talk
talk
about
about.
it.
Yes.
We'll talk a lot.
So please stay tuned. We have a lot to discuss about the various specialities where really plastic surgery plays a very important role. We'll be back again in our next show. Thank you so much for being with us. Thank you, Dr. Mohan.
And please be sure to like and subscribe and
Yes.
share this content, because this content is for you and for your friends,
Yes.
and for general knowledge of the public out there.
Absolutely. It's we have to work on this together. Yes.
Thank you.
Thank you so
Thank
much.
you so
Thank
much.
you.
Dr. Mohan Rangaswamy, turning your dreams into reality with precision and care.